My name's Sahil Parikh. I'm an interventional cardiologist from Columbia University, New York. And I've been asked to talk about something that we don't talk enough about at TCT, which is peripheral vascular disease, and specifically calcific SFA disease. We can certainly talk offline about large bore vascular access and iliofemoral disease as well. But I thought to get the conversation started, we'd talk about SFA disease. So this is a typical patient of mine. I was just talking to somebody about if you want to study calcium, there are certain ethnic populations that are especially plagued with calcific disease. And this is my patient from Brooklyn. So Brooklyn is a place where we see a lot of calcium because of some of the ethnicities there. I'll go back. This guy's 91. When I first met him, he's now 94. So this was 3 years ago. Had a lot of risk factors and had prior coronary disease. And he had rest pain and bilateral critical limb with Rutherford 4 disease and Rutherford 5 disease respectively. So he on exam has non-palpable pulses and had an ulcer on the left side. So we targeted his left leg first because he had CLI. And so you can see his inflow is relatively benign, but then he's got a short segment occlusion of the distal SFA. It's about 12 centimeters. This is the day in the life of the average interventionalist. And he's got disease that we typically, you can see on the unsubtracted images, looks not to be that tough, but we had to go subintimal to cross. We used a loop wire strategy with an angled nav across and a glide wire, and we're able to get across relatively quickly. And that's when the fun began. Because we were subintimal, we could not re-enter in the distal vessel. We had a really difficult time getting in, and ultimately I decided to, rather than going retrograde where he already had a malleolar ulcer, it was going to be difficult to get into his PT, we used an outback catheter. And so with the outback, we were able to get in to true lumen. And you can see down below there's heavy calcium in the P1 segment. We were able to get in and then confirm we were true lumen with a catheter injection. And now this is one of those situations where our normal treatment strategy, once we go deep subintimal and re-enter, we're almost always committed to avoiding atheroablative techniques to modify calcium. But here we found that there's 360 calcium. You can see on IVUS, there's 360 calcium. This is the kind of vessel that's not going to expand unless we do something to the plaque to modify it. And non-expansion or under-expansion is sort of a cardinal sin in these patients. They always restenosis. So here, because we were subintimal, we didn't want to use atherectomy. And so this was one of our early Shockwave cases in the registry, in the PAD 3 registry. So the patient, as you can see, got an M5 catheter. This is, I think, a 6060. And you can see we did serial dilatations, and we've learned over time that even in the subintimal space, you can do proper one-to-one dilatation with a Shockwave IVL catheter. And you can see on the right panel how much waste there was. And you can see after serial treatments, we were able to get this to expand and really get a proper lumen. And so this is the post-balloon inflation result on the left, and on the right is a post-stent result. Where we did a standard unsubtracted run. And you can see we got an excellent result. This vessel is still open 3 years later. He had infrapopliteal disease recur, and we had to come back and touch that up, but the SFA is wide open. And I don't think we could have gotten that kind of a result had we not done something to modify the plaque. The other thing that I thought was really important was that in the subintimal space, we don't have too many safe techniques for plaque modification. And with this device, we've learned since this case that in the subintimal space, there's really only one go-to technology, and that's this, because we have not, knock on wood, had a perforation. And we are very confident that it's safe to do, and it actually speeds up your case overall. It's great vessel prep for drug-eluting technology. It's great vessel prep for stents, especially here at Hunter's Canal, where compression and torsion are a big problem. If you don't get good expansion, stents are going to fail. So whether you use covered stents, Supera, or standard nitinol stents, or drug-eluting stents like Eluvia, this is a great vessel prep for all of them. And obviously now with new changes in the reimbursement landscape, there's less of a bar to worry about. You could really, even if you are able to do DCB POBO alone, you're able to get a really good angiographic result at the end of the case. So I think that for our practice, at least for mine, whereas we were using maybe a 30 to 40% atherectomy rate, that has gone way down, and we're using Shockwave in lieu of atherectomy in many of these calcific SFA cases. No embolic protection is required. We have really relatively rapid, catheter utilization. We don't have to prep. We don't have to worry about all kinds of mix of vasodilators and stuff. And we have really excellent experience with it now. So the key thing, I think, is sizing. What we've learned is that if you don't size properly, you don't get the kind of result you're looking for. So you have to be fairly aggressive with sizing. So if you're not sure, in that case, I would size up by at least 0.5 millimeter, if not more. And if you are looking to do proper one-to-one sizing, IVUS obviously makes it really easy. And in IVUS, we use a media to media measurement to get the proper size to really get good vessel expansion. Flow-limiting dissections are infrequent, and when you do have them, there's a host of ways to address that now because you've got good vessel expansion. So, I think that's a typical approach for us. We're using Shockwave in a large proportion of our SFA cases and our iliofemoral cases. We can certainly talk about below knee because that's an area of large unmet need with very few other competing technologies that are safe. But again, for the workhorse mainstream claudic patient with heavy calcium, this is a great approach. All right, well, with that, I thank you guys, and we look forward to seeing you at TCT this year and next. Thanks so much.